Hello, everyone. Welcome to the webinar. This is the new webinar. The topic today is Varicocele, addressing controversies, developing consensus, and crafting expert recommendation. Today with me are my colleagues, Professor Murad Gul, who is the scientific organizer of this program, and Dr. Rupin Shah, who's the co-chairman of this program. Just briefly about myself, my name is Dr. Ashok Agrawal, and I am the director of the Global Andrology Forum and responsible for helping to organize this program. This program is the first joint online meeting of the Andrology Working Group, which is the Society for Urological Surgery in Turkey in collaboration with the Global Andrology Forum. We have a great faculty today, and each group of the faculty is going to cover one topic. This first one is on varicocele, addressing controversies, developing consensus, and crafting expert recommendation. The first lecture will be by Dr. Hamoda, and it will be along with his team who are going to discuss this. The next one is by Dr. Amarnath Rambata and his team. Third one is by Professor Giovanni Colpi and his team. Fourth one will be given by Dr. Ramadan Saleh along with his team, and the last one by Dr. Basito and his team. We have, as of now, close to 1,000 delegates who have joined us. We have not done the count of the countries, but I believe that the number of countries is more than 60. 60 is the small number. So I think very happy joined to attend this unique program created by our group. And many of you have come from many parts of the world. We have majority of you are urologists and andrologists. This representation is an old one because the number has fallen now to close to 1,000. But we also have andrologists, biologists, embryologists, and other. The goals of this meeting is to address the controversies related to varicocele and male infertility, develop the consensus by discussion with the experts, and craft expert recommendation for the diagnosis and management of varicocele. Now, I hand over this presentation to my colleague, Professor Murad Gul.
Thank you, Professor Agarwal, for your great intro. I would like to thank you on behalf of our society for collaborating with us in this unique meeting. I believe both GAF and our Andrology Working Group are young initiatives, and we share the similar goals, similar enthusiasm, and similar excitements. And I hope in the future we will forward together and collaborate on other exciting projects. So I would like to briefly mention about Andrology Working Group. It was established in 2018. Our current chair is Professor Dr. Ümit Gül. We have more than 50 members for now, and we are working on infertility, erectile dysfunction, ejaculatory dysfunctions, hypogonadism and prostate disease, and female sexual health and LGBT. Our activities are writing textbooks, organizing surgical courses in Turkey, organizing congresses and workshops, and we carry out multi-center studies. So today in this webinar, we will cover the 5 important, most debated topics. The first one is the clinical and sonographic diagnosis of varicocele, and the other one is who should undergo varicocele repair. The third one is the technical aspects of varicocele repair, and the fourth one is the predictors of successful outcome after varicocele repair, and the last one is the special considerations for varicocele. After all talks, the discussion session will follow, and we will present the take-home message and conclude the meeting. Also, we set 5 learning objectives, the understanding the role of clinical examination and ultrasonographic diagnosis of varicocele. Our second learning objective is the revisiting the indications of varicocele repair. And the other one is the recognizing the varying methods of varicocele repair. And the next one is determining the successful outcome measures of varicocele repair. And the last one is the resolving the controversial areas for varicocele repair. So for this reason, one speaker and one moderator and 4 co-moderators were assigned to each topic. It may seem like a 10 minutes presentations to you, but bringing the state art of evidence and the massive, it requires a massive amount of work and time and energy. These all have been spent on this presentation. So as a first step, an outline of the related presentation was asked from the speaker. Once the outline was prepared, the speaker shared the outline with his teammates, and his teammates revised the outline and sent it back to the speaker. If there was an agreement on the outline, the speaker then again this time was asked to prepare his presentation, and the presentation went through the same steps until an agreement was set upon the presentation. As you can imagine, and in these steps, dozens of emails and files circulating among the groups. By this chance, I would like to thank all of the team members for their tremendous efforts to bring these presentations online. Well, this is our today's schedules. After all talks, we will start the discussions and conclude the meeting. And this is the flow of the meeting. Everything you can see is scheduled in an exact manner. Not only the speakers, but also the moderators and the co-moderators will comment and discuss the topic from the different aspects. Also, we set roles for each team position to avoid any confusion during the meeting. I would like to keep my presentation short in order to comply with the schedule. But by this chance, I would like to make an announcement on our approaching National Congress, which will be held between 9 to 13 November in Antalya. Professor Agarwal and many other international speakers will have lectures. You will find a very rich content. Please don't forget to register. Now it's time to move on to presentations. We will start with the Professor Taha Hamuda and continue with Dr. Amarnath Rammatla, Professor Giovanni Colpi, Professor Ramadan Saleh, and conclude with Dr. Rupin Shah. After the talks, do not miss the discussion sections. I wish you a good meeting. Thank you.
Hello and good day to all colleagues wherever you are. I just want to thank my JAF and Turkish colleagues for inviting me to this joint meeting on varicocele controversies. Since this presentation is a kick-off for the meeting, you might guess we will address the controversy on the diagnosis of whether clinical diagnosis or ultrasound diagnosis. Although this topic might seem like a simple one, in fact it's not, as a proper diagnosis is the road to proper management decision and better outcomes. Here we are going to address the controversy on the role of clinical examination versus ultrasound in the diagnosis of varicocele. And we will try to answer the question of, should we rely on physical examination alone or ultrasound alone for the diagnosis of varicocele? To perform a good and effective physical examination, we need to provide our patient with a warm room and ensure his privacy. The warm environment will allow relaxation of the dartus muscle of the scrotum, relaxation of the cremasteric muscle of the spermatic cord, and this will eventually facilitate the palpation of the cord. Examination of the patient in the standing position is crucial for palpating the varicocele. Also, performing a Valsalva is essential to increase the intra-abdominal pressure and to further distend the veins, and this will further facilitate clinical detection of varicocele. We should also repeat the exam in the supine position to ensure that the varicocele is reduced back and the veins are collapsed. By clinical examination, you may be able to palpate a varicocele, which is called clinical varicocele, with its different grades. Or you may not be able to palpate a varicocele, and in this last situation, there may be truly no varicocele whatsoever, or there may be a subclinical varicocele, which is a small varicocele that cannot be palpated during physical examination, but can be detected in imaging studies, mostly ultrasound study. The clinical varicocele can be graded according to the widely used classic classification system of Joubert and Amiller as grade 1, which is palpable only with Valsalva maneuver. Grade 2 is palpable at rest, and of course it will increase in size during Valsalva. And the grade 3, which is large enough to be visible through the scrotal skin, and palpable at rest. And again, it will increase in size during Valsalva maneuver. Although the physical examination has several advantages, being easy to perform in experienced hands and adds no additional cost to the patient, still it has several disadvantages. The physical examination is subjective, with significant interperson and even intra-person variability. In a study by Billet, they found 16% inter-observer variability for the assessment of varicocele evaluation. The physical examination has moderate sensitivity and specificity, about 70% for each. The practice guidelines have provided some recommendations on the physical examination. The AUA ASRM guidelines, they recommend varicocele diagnosis to be based on physical examination alone, and they suggest that ultrasound to be done only if physical examination is difficult, such as in situations with tight scrotum, small scrotum, thick spermatic cord, short cord, high riding testicles, and situations like that. And the AUA guidelines stated that the routine use of ultrasound to investigate presumed varicocele is to be discouraged. The EAU guidelines have provided also similar recommendations. The management of varicocele is still mainly based on physical examination, and they suggest ultrasound when physical examination is unreliable, challenging condition, or when recurrence or persistence of varicocele after varicocele repair is suspected. After you conclude your patient physical examination, you may ask, is physical examination alone is enough for the diagnosis? To answer this question, we need to understand the role of ultrasound in the diagnosis of varicocele. Varicocele appears in the ultrasound as anechoic and tortuous vessels in the vicinity of the upper pole of the testis. It has advantage of having high sensitivity and specificity, about 95%. Additionally, the ultrasound can provide assessment of the testicular architectures and any other associated pathologies. Similar to the physical examination, both the position and Valsalva maneuvers are essential for proper ultrasound examination. The patient is required to be examined in both supine and standing positions with and without Valsalva maneuver, while using a fixed location of the probe on the cord. The examination should provide measurements of the venous diameters and the presence of venous reflux. We have already mentioned these guidelines recommendations on the indications of ultrasound. Again, the AUA discouraged the routine use of ultrasound for non-palpable subclinical varicocele. And as you know, varicocele repair is not justified in subclinical cases, and thus the ultrasound findings wouldn't change the management of such patients. These guidelines have also provided criteria for ultrasound diagnosis of varicocele. The AUA recommend for diagnosis the presence of multiple veins with a diameter of more than 3 millimeters and the existence of reversal of blood flow during the Valsalva. They provided no further recommendations on the technical details. The EAU provided more detailed description of the criteria, suggesting venous diameter of 3 or more millimeters of the largest vein measured at any location, and venous reflux duration of more than 2 seconds measured in the upright position during Valsalva maneuver. The EAU guidelines have also suggested that the venous diameter and reflux may be utilized in the decision to treat. A large questionnaire survey study was conducted by the GAF and was authored by our colleague Dr. Roping Shah and other colleagues. The study has assessed the consensus and diversity in the worldwide practice patterns of varicocele management. The study has shown that despite the guidelines recommendations against routine use of ultrasound, still ultrasound is widely used to confirm the diagnosis of varicocele, with almost 70% of the respondents have based their diagnosis on combined clinical findings and ultrasound confirmations. 18% based their diagnosis on physical examination alone, while 10% went totally against the guidelines and used the imaging alone for the diagnosis. The study has also demonstrated variations in the venous diameter diagnostic threshold, with most of the respondents adopted vein diameter threshold of 3 millimeters. However, still 40% of the respondents used vein diameter less than 3 millimeters. Surprisingly, 11% of the respondents reported using 2 millimeter threshold, despite no supporting data for that. Ultrasound examination is simple and has high sensitivity and specificity, as we mentioned, but yet it still has several limitations. For example, the indications for ultrasound to diagnose varicocele are not well defined. The examination protocols are not standardized, and the proper position, whether supine versus supine, combined supine and upright positions, is not well determined. The cutoff for venous diameter and the duration of reflux during Valsalva are not consistent. So, several and different ultrasound grading classifications do exist. Importantly, the injudicious use of ultrasound can result in overdiagnosis of varicoceles and would lead to unnecessary surgeries and confusions about the outcomes. This is especially true for subclinical varicoceles. Based on our previous discussions, if no palpable varicocele during a physical examination, no routine ultrasound is required. With the absence of supporting evidence for repair of subclinical varicocele, routine ultrasound examination to look for or to search for subclinical varicocele is not justified, and the detection of subclinical varicocele can confuse the patient, can complicate the decision-making process, and can complicate the outcomes assessment. So the diagnosis of varicocele should be based primarily on physical examination and not on ultrasound alone. Still, ultrasound is useful in many situations, such as when physical examination is difficult or to confirm recurrence, as we mentioned, and to provide objective documentation prior to embarking to varicocele repair for insurance purpose and for medical legal issues. In a special situation of left clinical varicocele, ultrasound can help detect concomitant right subclinical varicocele. Several studies have documented yielding better outcomes when performing bilateral correction rather than unilateral left side varicocele repair only. This is, of course, different from the general recommendations advising against repair of subclinical varicocele. Our take-home message is the diagnosis of varicocele should be based on physical examination and may be confirmed by ultrasound. However, the decision to repair varicocele should be based primarily on the physical examination findings. Finally, here is a question again, which we skipped earlier in this presentation. Do you think we have gotten a clear answer for the question? I personally still doubt. Thank you for your good attention.
I'd like to thank the Society of Urologic Surgery of Turkey and Doctors Gul, Agarwal, and Shah for inviting me to speak today. I was asked to give a talk on who should undergo varicocele repair, when and why. And over the next 10 minutes, I'd like to review the indications for varicocele repair. We'll look at varicocele repair in the setting of isolated sperm defects, elevated sperm DNA fragmentation, and varicocele recurrence. We'll also review the data for varicocele repair prior to the use of assisted reproduction. We'll also review some of the female partner considerations that we should consider before varicocele repair, and when we should not operate on varicoceles. There are three main indications for varicocele repair. The first is an infertile man with a clinically palpable varicocele and abnormal semen parameters. Varicoceles have been recognized to affect male fertility, and repair of a varicocele can result in substantial improvements in semen analysis parameters and pregnancy rates. The typical pattern on a semen analysis from varicocele is the Oates pattern, or oligoastenoteratospermia. The second indication for a varicocele repair is in adolescents who have testicular hypertrophy. And this is usually manifested by a size discrepancy of greater than 20% between the ipsilateral and contralateral testicle. Occasionally, both testicles can be affected with impaired growth. The third main indication for varicocele repair is in patients that have chronic testicular pain associated with their varicocele. The pain is usually a dull, achy, heavy pain isolated to the testicle or spermatic cord. In this patient population, it's important to rule out other etiologies of the pain, and with careful patient selection, studies report about a 70 to 90% improvement after surgical repair. We can also consider varicocele repair for men that have isolated sperm defects. Isolated astenozoospermia is a diverse group of patients that have a wide clinical presentation, in the sense that a man that presents with 1% motility has a very different prognosis than someone who has 35% motility. In this setting, there's three main studies that have examined isolated as astenozoospermia in the literature. Two out of these three studies demonstrate improvement in total nodal count and pregnancy rates. There was a recent survey performed by the Global Andrology Forum in which 63% of experts that were surveyed would recommend a varicocele repair in the setting of isolated astenozoospermia. Isolated teratozoospermia is less sensitive and specific for male infertility, and in general, most experts are a bit hesitant to recommend varicocele repair as initial treatment in this setting. Out of three studies examining this specific scenario, only one shows an improvement in sperm morphology and pregnancy rate. However, it can be considered in select cases when other treatment options have failed. There are some specific situations such as globozoospermia, in which case a varicocele repair is not indicated as it will not correct the underlying etiology. Isolated necrozoospermia has an unclear etiology, but varicocele has been proposed as a factor. There are no published studies in the literature in this scenario. However, 42.5% of experts that were recently surveyed by the Global Andrology Forum would recommend varicocele repair in this setting. We need further studies to make definitive conclusions. Varicoceles are associated with higher sperm DNA fragmentation, even in the setting of a normal semen analysis. There have been 2 recent meta-analyses that showed improvement in sperm DNA fragmentation after varicocele repair by about 6 to 7%. Varicocele repair in men with elevated sperm DNA fragmentation should be considered, especially if there are no other factors or if there's been a previous ART failure. However, we do need future studies to assess improvement in pregnancy rates in this setting. Varicocele recurrence ranges anywhere between 1 and 15%, depending on what the initial treatment approach was. Recurrences are highest for the retroperitoneal high ligation, around 15%, and lowest for the microscopic subinguinal or inguinal approach of 1 to 3%. The recurrence is due to branches of the internal spermatic vein that were not ligated initially. Now, there can be other reasons for recurrence, such as gubernacular and cremasteric veins, but it's usually the internal spermatic veins that are the most likely cause. Treatment for a recurrence is usually recommended if the male patient is still infertile or if he's symptomatic with pain. The treatment approach should be different than what was utilized in the primary repair. For example, if a microscopic subinguinal approach was utilized, then one should consider radiographic embolization. There's 2 meta-analyses which showed significant benefit for a varicocele repair prior to assisted reproduction. The first examined men that were oligospermic and azoospermic and showed that there was an improvement in clinical pregnancy rate and live birth rate as evidenced by an odds ratio of 1.76 for both parameters. Another meta-analysis looked at all men undergoing varicocelectomy and identified an increase in clinical pregnancy and live birth rate as well. Infertility is a problem for couples in which both the male and female partner can contribute to, but if there's a big portion being played by a female factor, this needs to be considered. In some situations, it may make sense to proceed directly to ART as opposed to fix a varicocele. One of these scenarios may be advanced maternal age. Maternal age is a strong predictor of couples' fertility, and if a partner's age is greater than 40, we may not want to delay ART. Other things that we may need to consider on female partner evaluation are low ovarian reserve, blockages such as a fallopian tube blockage, and there are certain situations where a varicocele should not be repaired. The first is when there's a subclinical varicocele, or if there's a varicocele in the setting of a normal semen analysis and normal sperm DNA fragmentation. In these scenarios, there's not much evidence that a varicocele repair will improve pregnancy outcomes. Also, if IVF is necessary due to a female factor, it may be better to proceed directly to ART. I want to end with some take-home messages. Varicocele repair can be considered for infertile men who have abnormal semen analysis or sperm DNA fragmentation. It can also be considered in the setting of testicular hypertrophy or for chronic scrotal pain. A varicocele repair before ART can help improve pregnancy and live birth rates. And we need to always consider female factors prior to performing a varicocele repair. Thank you, and I'd be happy to take any questions at this time.
Dear colleagues, my sincere thanks to all the organization committee and my session team members for assigning me the honor of presenting this lecture on technical aspects on varicocele repair. The first question is, which surgical technique should be used for varicocele repair? Which is the best? Varicocele repair can be done by classic surgery, that is with supraunguinal retroperitoneal incision of Ivanisevic, or inguinal or subinguinal incision, by microsurgical inguinal or subinguinal approaches, by radiologic retrograde scleroembolization, by robotic assisted surgery, by laparoscopy, or by antegrade subinguinal or scrotal sclerosations, the latter one with or without radiologic guidance. A famous meta-analysis of 36 studies by Kayan concluded that the microsurgical techniques can obtain the highest spontaneous pregnancy rate with the lowest recurrence rate, followed by the Ivanisevic technique. This result was confirmed by a subsequent meta-analysis on randomized controlled trials, including more than 1,000 patients by Hui Ding, here below, showing a significant advantage of microsurgery over open varicocelectomy in terms of a higher pregnancy rate and lower recurrence and postoperative hydrocele rates. Robotic-assisted surgery still needs large studies to draw valid conclusions based on a review by ITAFE. Taken into account that in general surgical repair of clinical varicocele leads to highly significant improvement in sperm count and motility, regardless of surgical technique, according to Schauer, which also claimed the superiority of inguinal varicocelectomy versus eye ligation and subinguinal approaches, a subsequent multiple treatment meta-analysis on 10 methods of varicocelectomy and embolization or sclerotherapy by Jun Wong on 36 controlled trials or studies further confirmed the superiority of the inguinal microsurgery in terms of pregnancy rate, improvement of sperm density and motility, and overall complications, and of subinguinal microsurgery about recurrences and postoperative hydrocele. Comparing the available data in the wide literature from 94 up to date about multiple clinical experiences with the different techniques, once again microsurgical approaches present the lower recurrence and complication rates, although with disadvantages of a higher cost and the microsurgical experience required. The Ivanisevic is burdened by a higher rate of late relapses. Scrotal or subinguinal sclerosation, my personal experience is large in the latter, are easy in large varicocele, otherwise require at least a minimal ability in managing tiny vessels. Palomo is very rapid, but often involves artery ligation, which seems fully illogical. Radiologic scleroembolization is a field for expert radiologists or radiourologists, presents a high recurrence rate and can be useful to treat unexplained relapses by assessing venous drainage anomalies. Laparoscopic approach may be used for the rare bilateral clinical varicoceles, but is expensive, requires surgical experience, and has the fee of high recurrences and possible severe complications. In the clinical practice of varicocele repair, there is a competition between urologists and operative radiologists. The most recent Cochrane meta-analysis by Persad last year concluded that there is insufficient evidence to determine where surgical treatment is superior to radiological treatment in terms of live birth rate and varicocele recurrence, and also the evidence on adverse events, hydrocele formation, pain, epididymitis, hematoma, and suture granuloma, resulted inconclusive. Indication and relative contraindication for radiologic percutaneous scleroembolization are presented here below in the slide, but rightly may be a good matter of discussion. In In this debate, nobody denies that embolization is a safe and cost-effective procedure, although with a small risk of technical failure and higher recurrence rate. Overall technical success rate reported in the literature is more than 90%. However, it is excellently successful in case of recurrent varicocele, from 93 to 100%. We can conclude this main chapter by affirming that microsurgical inguinal approach is considered the gold standard in terms of effectiveness, low recurrence rates, and adverse effects. However, in varicocele recurrence and in bilateral clinical varicocele, the study of venous anatomy with phlebography remains highly suggested. Some additional details remain to be clarified. First, is gubernacular veins ligation useful? According to a recent meta-analysis by Beaulieu, microsurgical varicocelectomy with testicular delivery and ligation of gubernacular veins and basal veins leads, compared to not performing those steps, no beneficial influences on sperm parameters, pregnancy rate, and live birth rate. More adverse effects, that is, scrotal edema or cupidoedematis, etc., and lower recurrences require, in addition, a longer operation time. Although Wald in 21 reported that it is associated with improvement in testosterone levels, and Alame in 18 reported a significant difference in improvement in sperm motility, certainly randomized controlled studies will be useful to draw more solid conclusions. Second, is microscope or magnifying loops essential for varicocelectomy? An atomic study showed that venous drainage of testis epididymis is accomplished by the internal spermatic, differential, and external spermatic, that is cremasteric veins, which anastomose at the caudal pole of testis, and then via the gubernacular veins with the posterior scrotal veins, and that other anastomosis exists between a cremasteric branch and the anterior scrotal veins, which gives the external pudendal vein. Therefore, subinguinal approach offers full access to all varicose spermatic veins and collaterals. Microscopy-aided surgery offers identification of small veins, preservation of arteries, lymphatics, and nerves, and appreciation of spermatic cord of fascia, which permits the development of two surgical planes. The plane of internal spermatic vessels, there the internal spermatic veins are ligated, whereas the testicular artery and the derivation as well as lymphatics are preserved, and the plane of cremasteric vessels and vas. Here the cremasteric veins are ligated, whereas the cremasteric artery, vas deferens, and its vasculature, lymphatics, and the genital branch of genitofemoral nerve are preserved. At the end, the venous return is affected by the differential and scrotal veins, or when the gubernacular veins are ligated, by the differential veins only. Obviously, surgical results might be better by an operative microscope due to its higher magnification power and moderately less by using magnifying loops. This figure shows a transversal section of the spermatic cord, the testicular artery surrounded by the anastomizing veins of the plexus immersed in the cord fat, and beside the vas deferens with its vessels. At the follow-up of a microsurgical subinguinal varicocelectomy, the ultrasonography after 6 months showed a significant peak systolic velocity increase in the testicular artery, and the testicular artery and capsular artery resistive index decrease compared to the ultrasonographic controls after 3 months, and even more to those preoperative. Summarizing, microsurgical subinguinal varicocelectomy resulted clinically effective in improving the global semen quality and the most relevant parameters, including the sperm DNA fragmentation index. in improving pregnancy outcomes in varicocele patients with high sperm DNA fragmentation and also the residual spermatogenesis in those with non-obstructive azoospermia, in pain relief, in lowering the recurrence rate, and in lowering postoperative complication, that is bleeding, hydrocele, hematoma, testicular atrophy. In addition, it warrants very low rates of vas deferens injury, wound infection, epididymitis, and can increase the testosterone serum level. Certainly, loop-assisted high inguinal varicocelectomy is a safe, simple, and effective method for the treatment of superfertile men and could be recommended especially for medical facilities without any microscopic equipment. The above shown meta-analysis argue persuasively that microsurgical varicocelectomy decreases complications, although at the cost of longer surgery, and actually validate microsurgery in varicocelectomy. I will conclude with a last detail related to the use of intraoperative Doppler ultrasonography. Specific experiences show that by this method, the numbers, sizes, and location of spermatic vessels in each site are recorded during operation, and statistically significant greater numbers both of arteries are identified and preserved, and of internal spermatic veins are ligated, both in primary and recurrent varicoceles. Oz-Kaptan in 20 and Guo in 17 showed, respectively, further higher postoperative sperm motility compared to no use and lower incidence of complications. I thank you, all of you, really, for your kind attention.
Hi, everybody. First of all, I would like to thank the organizing committee for inviting me to this important meeting. My talk today will be focused on the predictors of successful outcome after varicocele repair for treatment of male infertility. In the first part of this presentation, I will highlight the post-operative parameters which are considered as the main outcome measures of varicocele repair for the purpose of male infertility treatment. And in the second part, I will discuss the predictive potential of different preoperative parameters for successful outcome of varicocele repair. According to the most recent guidelines published by the AUA, ASRM, and EAU, the three societies consider semen parameters and pregnancy rate as important reproductive outcomes following varicocele repair. And in addition, the EAU guidelines refer to the significant role of varicocele repair in terms of reducing sperm DNA fragmentation and reducing seminal oxidative stress level. Also, a recent systematic review by Cochrane indicates that spontaneous pregnancy rates and live birth rates are the most important outcome measures of varicocele repair for infertility treatment. In a recent interesting study which is conducted by the Global Andrology Forum and was led by Dr. Ashok Agarwal and Dr. Rupin Shah and published in the World Journal of Men's Health early this year, 574 clinicians from 59 countries were asked about what they consider as the most important outcome measure for varicocele repair. And the results of this interesting study indicate that more than 70% of participants selected basic semen parameters as the main or primary outcome measure, while 16% of participants selected pregnancy rates and less than 10% of participants selected live birth rate as their primary outcome. Regarding the different preoperative parameters which can be used as predictors of outcome of varicocele repair, these preoperative parameters can be classified into three main categories. These include patient-related parameters, varicocele-related parameters, or procedure-related parameters. Let's talk a little bit about each of these items. Regarding patient age, in a large series of over 350 men with a mean age of 36 years, the patient age was found to be negatively correlated with the percentage improvement of sperm motility and sperm morphology. Generally, younger age was found to be associated with better reproductive outcome following varicocele repair. Body mass index is inversely correlated with the incidence of varicocele. However, the body mass index was not found to be predictive of any change in semen parameters following varicocele repair for the purpose of treatment of male infertility. While duration of infertility was negatively correlated with spontaneous pregnancy rates following varicocele repair. The testicular volume was not found to be associated with the reproductive outcome after varicocele repair in one study, while other researchers found larger testicular volume to be predictive of favorable reproductive outcome. The preoperative sperm parameters, when sperm concentrations are greater than 5 million per milliliter or total motile sperm counts are greater than 5 million sperms, this is also associated with higher natural pregnancy rates following varicocele repair. Regarding the preoperative reproductive hormones, the low baseline serum FSH and high total testosterone levels remain the only two hormones which demonstrate a correlation with improvement of semen parameters after varicocele repair. Regarding the parameters which are related to varicocele, one of the important parameters is the grade of varicocele, and the EAU guidelines state that a higher grade of varicocele is associated with greater improvement. And there was also a study using predictive nomographs which indicated that varicocele grade impacts all post-operative semen parameters following varicocele repair. Also, some studies investigated the role of the number of veins and their impact on the outcome. And it was found that when the number of veins is more than 9 ligated veins or more than 10 veins, this is usually associated with significant improvement in sperm parameters as compared to men which have less number of veins. The laterality of varicocele is also an important subject, and a recent meta-analysis reported no significant difference in the percentage increase of sperm concentration and motility in bilateral versus unilateral varicocele repair groups, but the odds ratio for spontaneous pregnancy rate was 1.7 in the group with bilateral varicocele repair. Another more recent meta-analysis also concluded that bilateral varicocele repair is superior to unilateral varicocele repair in terms of the reproductive outcome. The AUA and ASRM guidelines also comment on the technique of varicocele repair, and they recommend surgical varicocelectomy and also indicate that the highest success is shown with subinguinal microsurgical varicocelectomy. Similarly, also the EAU guidelines indicate that microsurgical varicocelectomy is the gold standard and the most effective among the different techniques for varicocele repair, having the lowest complication and lowest recurrence rate. However, the EAU guidelines indicate that adequate support from randomized control trials is lacking and other techniques are also viable options. In conclusion, the current research on predictors of successful outcome for varicocele repair for treatment of male infertility is limited, and the limitations include small sample size of the studies, the retrospective nature, the heterogeneity of the studies, and the difficult adjustment for confounders. Several factors may help achieve better reproductive outcome following varicocele repair, and these include young age group with short duration of infertility, larger bilateral varicocele with normal sized testes, normal serum levels of FSH and total testosterone, and the use of subinguinal microsurgical varicocele as a technique. And with this, I come to the end of this lecture, and thank you all for attendance.
Good day. It's been a wonderful meeting, and we've covered most of the aspects related to varicocele. Thank you for inviting me to be part of this meeting. Thank you to my moderator and co-moderators for their inputs. A few questions remain to be wrapped up, and we will try and answer these. We will define the question, look at global clinical practices as derived from the global survey which we conducted last year and have published this year and as strongly recommended reading. We will compare these practices with the official guidelines and finally come up with an expert opinion. So the first and very controversial question, that is there a role for varicocele repair in men with NOA, non-obstructive azoospermia? Will it help sperm appear in the ejaculate? And if not that, will it improve the sperm retrieval rate? When we did the survey, we found that the opinion was equally divided. Half the respondents said we never or only very rarely offer varicocele repair, and the other half said yes, we do, with 1/4 offering varicocele repair to more than 50% of their patients. The guidelines are also equally divided. The AUA states couples should be informed of the absence of definitive evidence supporting varicocele repair, whereas the EAU says that varicocele repair may result in the appearance of sperm in 20 to 50% of cases and will also improve the odds ratio of sperm retrieval. The expert opinion also reflects this controversy and states that the evidence is limited. We could offer varicocele ligation in some cases based at the discretion of the clinician and with a proper discussion with a couple of the possible benefit or lack of benefit. And they also warn that if sperm appear after varicocele repair, these samples should be cryopreserved because it's often possible that the man could become azoospermic again. Related to this is another question that if one is doing varicocele repair for a man with azoospermia, should one do a testicular biopsy? Is there a role for it either before or during the varicocele repair? Again, when we look at a survey, opinion very divided. Almost 43% say we never do a biopsy or rarely do a biopsy during varicocele repair for azoospermia, whereas the other 47% said that occasionally or usually they would do a testicular biopsy. Again, the guidelines have no recommendation, but when we look into literature, there are many papers showing that biopsy does predict the outcome. If a man has late maturation arrest or severe hypospermatogenesis, in about half the cases, you could expect sperm to appear in the ejaculate, whereas if the biopsy shows Sertoli only or early maturation arrest, the likelihood of finding sperm is very rare. And so the expert opinion on this is that, again, it's controversial, but one could consider a diagnostic biopsy either before doing the varicocele repair and take a decision to operate or not operate based on the biopsy, or if one is doing a varicocele, do a biopsy at that time, so at least one can give the couple a clearer prognosis and decide how long to wait. There are two additional benefits of doing the biopsy. One is that if you do find sperm in the biopsy, then the IVF lab could freeze those sperm, so one need not wait for any more time. And two, the histopath of the biopsy would help rule out intratubular neoplastic changes, which would have prognostic significance. Equally controversial topic, should a subclinical varicocele be repaired? Is it of any benefit to the patient? So again, the guidelines are very clear. AUA, ASRM, EAU do not operate a subclinical varicocele, but global practices seem to vary considerably from this. So in a survey, when the respondents were asked, will you do an ultrasound in a man with no clinical varicocele? Half of them said either, always, or usually, suggesting that they would look for a subclinical varicocele. And when they were asked, will you repair a subclinical varicocele? Only 45% said they would not, which means at least half of the respondents will operate a subclinical varicocele either occasionally or if medical therapy has failed in an attempt to improve semen parameters. So the expert opinion on this is, again, unequivocal that subclinical varicocele currently should not be operated. If it's a grade 1 early clinically obvious varicocele, you could operate, but with a very guarded prognosis. And given this controversy and disparity between clinical practice and guidelines, further research is warranted on this subject. Now, this question also extends into another clinical scenario. What if you have a large left clinical varicocele, grade 3? But on the right side, there's no obvious varicocele, but ultrasound shows reflux. So you have left clinical varicocele, right subclinical varicocele. Should you operate only the left side, or should you operate both sides? Now, again, in the global survey, 2/3 said they would not operate the right side if it is subclinical. They would operate bilaterally only if the right side was clinical. The guidelines also say the same, do not operate a subclinical varicocele. But literature has a different perspective. We have 3 major studies available, 2018. A large meta-analysis of 4 studies showed that in men with left clinical, right subclinical varicocele, the semen parameter change was the same whether you operated bilateral or unilateral, but the pregnancy rate was significantly higher in the bilaterally operated group. Another large randomized control study published in the same year, 179 patients in each limb, showed that both the semen parameters and the pregnancy rates were higher when bilateral surgery was done instead of only unilateral on the clinical side. There is a third smaller study that supported no benefit from bilateral versus unilateral. So the expert opinion seemed to favor global practices not to operate bilaterally. However, given the weight of the evidence available, the expert opinion is that you could consider bilateral surgery in this situation after a discussion with the patient of the pros and cons and the additional burden of a bilateral surgery. Finally, is there a role for medical therapy, particularly antioxidants, in men with varicocele, either before surgery or after surgery? Again, if you look at the global survey, opinion fairly favoring the use of antioxidants. So you have the large blue chunk, which is 43% saying that they will advise varicocele ligation first. But if the men do not improve after varicocele ligation, they would consider antioxidant therapy. And you have 25%, the pink box, showing that almost 1/4 of men would, in fact, 1/4 of respondents would, in fact, first give medical therapy, antioxidants. And if the man did not improve, then proceed with varicocele ligation. We've just completed a huge meta-analysis, which is going to be presented at the ASRM now. And that showed that there was improvement in conventional semen parameters, count motility, total motility, and in the pregnancy rates after giving antioxidants in both groups, those men with varicocele who were not operated and those men whose varicocele was operated, thus suggesting that though there are no guidelines on antioxidants in men with varicocele, the expert opinion definitely favors the use of antioxidants, either as a medical therapy before surgery or after surgery. So to summarize, varicocele repair could be considered with a very guarded prognosis in men with NOA. A biopsy may help guide the prognosis. Bilateral subclinical varicocele not to be corrected, but if left is clinical, right is subclinical, there may be a role for bilateral correction. And finally, there is a role for antioxidant therapy. So thank you very much. It's been a pleasure participating in this meeting, and we look forward to the discussion.
Hello, everybody. I would like to thank all speakers for excellent presentations. Now I want to summarize some key points in Professor Taha's presentation. First, proper varicocele diagnosis translates to appropriate treatment. This diagnosis is a crucial step in managing varicocele. Physical examination is the primary method in diagnosing varicocele. However, it has several limitations due to its subjectivity and inter-observer variability. For inconclusive physical examination, we can use an ultrasound to aid diagnosis varicocele. Both AUA and AAO guidelines have a similar recommendation for diagnosing varicocele. That is, the ultrasound is not routine unless when physical examination is inconclusive. Global survey conducted this year, 2022, by our colleagues, Dr. Rupin Shah, revealed that ultrasound is still widely used to confirm the diagnosis of varicocele. However, different grading classification exists, making improper use of ultrasound and resulting in poor diagnosis of varicocele. In general, no palpable varicocele means no routine ultrasound. Diagnosis should be based on physical examination and ultrasound, but the decision on varicocele repair is based on physical examination. A question raised by Professor Taha is physical examination alone enough for varicocele diagnosis? For this presentation, there are some comments and questions from co-moderator. I would like to invite Dr. Mohamed Arafa from Egypt or Qatar to give comments or questions. Please, Professor Arafa.
Thank you, Dr. Bonko. Thank you, Dr. Taha, for a nice presentation. I just have one comment to reiterate on the scrotal ultrasonography. We have to say that it has to follow the same guidelines as the examination. So it must be in a warm room. It should be done the patient in the erect position, then in the supine position. We prefer to start with the erect position. This will keep the veins engorged and will help us easier diagnose varicocele, especially with grade 1 and grade 2. Because if we start with the patient in the supine, the veins may be de-engorged, and it may take some time to engorge again, giving us the actual size of the veins. So this is why we recommend using first in the erect position, then in the supine position. Well, so we need to hear your comment for this, Dr. Taha. Thank you very much.
Okay, thank you, Professor Rafa. The next question will be asked by Professor Imad Sizo from Morocco. Please, Professor Imad.
Thank you so much, dear Professor Taha Hamouda, for this excellent talk. I have a question. After varicocele repair, some residual dilated veins may persist. For example, we can have a preoperative grade 3 and achieve a clinical grade 1 postoperatively. So given the subjectivity of physical examination, is there an interest or an added value of ultrasound in comparing preoperative and postoperative vein diameters and also the reflux durations? Thank you.
Thank you, Dr. Professor Imad. The last question from the co-moderator. I would like to invite Dr. Mesut Berkanduran from Turkey to ask some questions. Please, Dr. Mesut.
Thank you, Dr. Panko. First of all, I want to thank all speakers and moderators for this informative meeting. Professor Taha made clear so important points. As he emphasized that we use ultrasonography for the diagnosis of varicocele, I wonder if there is any evidence or relationship between ejaculation and the ultrasound performing time. And moreover, should we perform ultrasonography before ejaculation? If not, is there any cutoff time to perform ultrasonography after ejaculation? Thank you very much.
Okay, thank you, Dr. Maksud. Then I would like to invite Dr. Professor Taha to respond to those questions and comments. Please, Professor Taha.
Thank you very much, Professor Ponku, and all colleagues for your valuable comments and questions. I agree with Professor Arafa, very important comment. And I also agree that every effort should be done during physical examination and ultrasound examination, especially to detect equivocal cases. For ultrasound, we should also follow the same requirements for effective physical examination, such as ensuring a warm and private flow, examination while in standing and supine positions with and without Valsalva maneuvers. Some colleagues suggest also a short active exercise before physical examination, such as active walking around for a few minutes to improve the accuracy and the detection of varicocele in the scrotum. And as you know, Dr. Arafa, most andrologists prefer starting performing physical examination in the standing position first, followed by the supine position. And of course, it makes sense to replicate the same during ultrasound examination, as you suggest. However, I believe if someone starts his physical examination or ultrasound examination in the supine position, then the erect position, if we perform and instructed the patient to perform effective and proper Valsalva maneuver, this can cause tremendous increase in the intra-abdominal pressure, which is usually sufficient to encourage the veins again during the changing of the position. And now for the interesting question of Dr. Ahmed. The short answer for your question, Dr. Ahmed, is yes. Yes, ultrasound is very useful when you suspect varicocele recurrence or persistence. And this is also clearly emphasized in the AUA and EAU guidelines. But to elaborate in your question, I need to address 2 points. The first one, there is no global consensus on the exact cutoffs for the venous diameter or the duration of reflux to diagnose the primary varicocele. Anyhow, I believe the cutoffs of more than 3 millimeters of diameter for the diameter and more than 2 seconds for the reflux, as suggested by the EAU guidelines, these parameters is still applicable when we are considering recurrence. The second point for evaluation of recurrence, we depend on some more and other additional criteria, not only the ultrasound findings, such as if the recurrence is clinical or subclinical. This is very important finding we should look for. And if there is any continued impairment of the semen parameters or the infertility status. We should also look for any associated symptoms. And very important, we should consider the previously used technique for varicocelectomy to direct our management. And now for the last question of Dr. Duran. Dr. Duran, you raised a very interesting question on the relationship between timing of ejaculation and scrotal ultrasonography. In fact, this question is very tough to answer, at least for me. We know that ejaculation can impact the seminal vesicles volume and the size of the epididymis. But I'm not aware if this can directly impact the testicles or the veins. And also, I'm not familiar with any specific recommendations regarding the ejaculation or particular abstinence period for performing scrotal ultrasound. Of course, it will be very interesting if some studies can provide an evidence in this regard. I believe I have addressed all the raised points by the moderators, and thank you all again. I have received some questions for from the audience. For the sake of time, I will respond by email for these questions. Thank you very much all. Thank you.
Okay, thank you, Professor Taha. I think we still have 2 or 3 minutes. There is a question from the. Is it okay for you?
Okay.
Okay, there is a question.
Yes, I see Dr. Hashimi.
Yeah, Akim Sikiru. Yeah?
Yes, Dr. Hashimi asking if
which animal study is better for the varicocele?
Yes. Yeah. I have here Dr. Hashimi is asking for SDF, if there is high SDF and subclinical varicocele. Can we do repair or not for this? I think the recommendations is not to perform repair for subclinical varicocele, and we should direct our approach for elevated SDF by other methods for management rather than repair of varicocele. And for it's possible to diagnose varicocele without ultrasound. It depends on the operator skill. Yes, as I have mentioned in the presentation, the diagnosis is based basically on the physical examination, and you can confirm your examination with ultrasound. For the sake of confirmation, documentation, medical legal issues for reimbursement by insurance companies and issues like that. But for the decision on surgery, you should rely on the findings of the physical examination rather than the findings of the ultrasound, because ultrasound, there is no standardized diagnostic criteria and no standardized grading systems still up till now knows for the varicocele by ultrasound examination. I think I would, any more questions? I think the other questions are directed for my colleagues.
Yeah, okay. Thank you, Professor. I think it's already clear from your presentation and your answer from the comments or question from the moderator and also from the audience that we have to we can do the ultrasound examination to make complementary of our physical examination, but the decision whether we want to repair or not, it should be on our physical examination. Okay, thank you very much, Professor Taha, for excellent presentation, and to all moderators, very nice comments and questions. Professor Taha has already responded clearly to all comments and questions. For those who have questions, we can raise the question and we will answer the question by email. This will conclude our session, and I will ask Dr. Gian Maria Salvio from Italia to chair the next session. Please, Professor Gian Maria.
Is it better now?
Please.
Okay. Hi everyone. Thank you, Dr. Birowo, for your timely presentation and for your excellent moderation of the discussion. I'm Dr. Gian Maria Salvio from Ancona, Italy, and I'm very glad to be here to moderate the second session and to talk about the presentation of Dr. Amarnath Rambatla. To summarize the key points of his presentation, Dr. Rambatla showed us what the indications for the varicocele repair are. And to summarize, we have a clear indication to varicocele repair that are, first of all, infertility with palpable varicocele and abnormal semen parameters. Second, adolescents with testicular atrophy. And third, chronic testicular pain. Dr. Rambatla also showed us less clear indications for varicocele repair that are isolated sperm abnormalities, such as astenospermia and teratospermia, where no clear consensus exists, and high sperm DNA fragmentation that could be an indication for varicocele repair, but that needs more research. Unclear indication remain the necrosospermia, whereas another indication to varicocele repair could be to correct a varicocele found in a man from a couple undergoing ART. But if ART is chosen due to a female factor, varicocele repair is absolutely contraindicated. Varicocele repair is contraindicated for subclinical varicocele and normal semen analysis and normal sperm DNA fragmentation as well. Now I would like to invite Dr. Gökhan Şeker from Turkey to ask questions and to give his comments to Dr. Rambatla's presentation.
First of all, we would like to thank Dr. Amarnath for his wonderful presentation. I have two questions. Firstly, in the presence of grade 3 varicocele in adolescents, if semen parameters and testicular size are normal, but testosterone level is low, would you recommend varicocele repair? Have you observed that varicocele repair can lead to hormonal improvement in your clinical follow-up? The other question is, would you recommend performing varicocele repair in the presence of isolated oligospermia? Thank you very much.
Thank you, Şeker, for your questions. And now I invite Dr. Erman Ceyhan from Turkey to ask his questions.
Thank you, Yemer Sabri. Thank you, Amarant, for your nice presentation. I would like to ask, should we use sperm DNA fragmentation index as an indication for varicocele repair in young men who are not yet aware of their fertility potential? And also, using a sperm DNA fragmentation index, can we use it as an indicator for varicocele repair in recurrent patients? Thank you.
Thank you, Herman. Now it's the turn of Dr. Vineet Malhotra from India. Please, Dr. Vineet, ask your questions.
Thank you, Jimmy. I would like to congratulate Dr. Amarnath for an excellent talk and a few comments from him. One on what is indication for varicocelectomy in a subclinical varicocele, the setting of bilateral varicoceles where the other conditions are fulfilled. And does he have a word of caution for varicocelectomy in men with non-obstructive vasospermia, especially with regards to a clinical grade?
Okay, thank you, Vineet. And Dr. Tanli, I invite you to ask your question and to put your comment. Go on, please.
Thank you, Jimmy, for introducing me. Thanks, Dr. Amar, for his great presentation. So he had a review for us the indication of varicocele repair and when to repair it. He also explained that shortly why we have to do varicocele repair in this group of patients. So there are three main indications for varicocele repair. The first one is infertile men who have abnormal semen analysis or SDF. The second is the testicular hypertrophy, and the third one is chronic menstrual pain. However, the female factor and the age have to be considered prior to varicocele repair. And besides, and I agree with him that in the future we should research more about the indication of varicocele repair in the male with necrozoospermia, severe oligozoospermia, or azoospermia due to the lack of evidence base up to now. Thank you.
Thank you, Dr. Tan. Okay, now we have time to listen to Dr. Rambatlat's answers to our questions.
Thank you, Dr. Salvio. So, these are all excellent thoughts and questions and sort of highlight some of the controversies surrounding varicoceles that we deal with. And so it seems like there's a few main issues. One is, do varicoceles affect hormonal status? And then varicocele repair in the setting of isolated oligospermia. And then I'll address varicoceles with sperm DNA fragmentation as a marker for varicocele repair. And then we'll finish off with varicoceles in the setting of a bilateral varicocele, clinical on one side and subclinical on the contralateral side. So starting off with the first point from Dr. Seeker. So we know that varicoceles can cause Leydig cell dysfunction as well as deficits in spermatogenesis. And this has been well documented. And likely by fixing the varicocele, studies have shown that you may see an improvement in testosterone of about 60 to 100 points, depending on which study or meta-analysis we look at. But we have to keep in mind that this is largely from a data set of patients that are infertile, and the patient population that tends to see the most benefit are infertile men that are also hypogonadal to begin with. Now, we have to consider the patient population that we're looking at that are presenting for hypogonadism. And these are generally men in their 50s to 70s who are no longer interested in future fertility. And so in this setting, when they're not interested in future fertility, there are much more effective methods to raise testosterone levels in this population with conventional testosterone replacement therapy. So in the setting of just trying to improve hormonal function, if a man is not looking for future fertility, I typically don't offer a varicocele repair in this setting for that reason. But in a younger man, if future fertility is of importance, then this is definitely something that can be discussed and considered. In our adolescent population, I tend to be a little bit more conservative because we don't have established normal ranges for sperm semen analysis parameters as well as testosterone levels, and these can sometimes change over time as adolescents are growing into young men. And so, so for the specific question, in an adolescent that has normal semen analysis parameters, normal testicular volume, but abnormal hormonal profile, I would probably place this adolescent into a category where I'd perform close surveillance. And in the meantime, incorporate other methods to improve testosterone, such as dietary, lifestyle, exercise modification regimens, and follow him over time before offering a varicocele repair for that specific setting to raise hormonal function. In the setting of isolated oligospermia, I think we have to kind of extrapolate from other studies that show a good improvement in sperm concentration and an improvement in pregnancy rates in general with varicocele repair. And we can extrapolate data from these studies to show that likely that if someone has isolated oligospermia, they'll probably have some improvement in their sperm concentration after fixing the varicocele repair. So I think this is a reasonable scenario to offer a varicocelectomy or embolization. In a young man with sperm DNA, elevated sperm DNA fragmentation, who we don't know their fertility potential. So I'm assuming this is a young man that has normal semen analysis parameters and normal hormonal function. Because if they have abnormal semen analysis parameters, that may be a reason by itself, aside from the elevated sperm DNA fragmentation, to offer a varicocele repair. It may be signs that there's testicular damage occurring, and because varicoceles can have a progressive effect over time, it may be something to consider to fix the varicocele early on. And so we don't have a lot of evidence that sperm DNA fragmentation can deteriorate over time or worsen over time. So again, in someone that hasn't tried to have proven fertility, I think it's reasonable to monitor this patient, and closer to when they're ready to conceive, if they're having difficulties, then repair the varicocele at that time. And then in the scenario of a bilateral varicocele, so subclinical on one side and clinical on the contralateral side, there's in general, we don't recommend fixing subclinical varicocele, but this may be a situation in where there are studies to show there's an improvement in progressive motile count, there's an improvement in sperm morphology, there's an improvement in overall spontaneous pregnancy rates after fixing a bilateral varicocele with a subclinical on one side. There was a nice meta-analysis that looked at 4 randomized controlled trials that demonstrated this. But on the flip side, there needs to be a discussion with the patient, because there is an increased risk to performing a bilateral operation. And the risks and benefits need to be weighed. There's probably not a clear right or wrong answer in this scenario. And this is something where, sort of the art of medicine comes in. There needs to be informed decision-making between the physician and the patient prior to proceeding in this scenario. But it's something that's certainly reasonable and can be considered. Thank you.
Thank you, Dr. Rambarkla. You were very clear. Okay, we are out of time, so I think that it will be better to invite to chair the next session the Dr. Germar Pingera from Austria. Thank you to all the co-moderators, and thank you again, Amarnath, for your very wonderful presentation.
It's Liv, go on.
You can start.
You can start.
Okay, fine. My name is Pingera, and I am the moderator from the team 3. It was a great pleasure for me, and certainly for all the Congress participants worldwide, to listen to Professor Kolbe's excellent presentation on such an important topic about the surgical treatment possibilities in varicocele repair. Now, I want to summarize some key points in Professor Kolbe's presentation. First of all, Professor Kolbe gave us a clearly structured overview about different techniques in varicocele repair by highlighting the advantage of each surgical approach. We learned about reported data from RCTs and meta-analysis. The spontaneous pregnancy rates and the recurrence rate after varicocele repair, but also possible surgical associated complications were analyzed in detail. And honestly, as a surgeon, we should always be aware about any complication in treating this couple of men. According to the meta-analysis, the microsurgical approach appears to exhibit some strong benefits. Furthermore, Professor Kolbe analyzed in his talk the up-to-date published studies about radiologic interventions for varicocele repair. Apparently, there is no universal and global accepted consensus about the superiority of microsurgery varicocelectomy compared to novel radiologic interventions, basically by examining postoperative outcomes assessed by total sperm count, sperm motility, pregnancy rate, and recurrence rate. Finally, after explaining the vascular anatomy, Professor Kolbe stressed the value of scrotal ultrasound. For example, he reported by assessing the resistive index, whereby he showed that in one study, 6 months after microsurgery, the peak systolic blood flow in intratesticular vessels appears improved. Apparently, it seems that anatomic knowledge and preservation of arterial supply appears crucial. The role of endocrinological benefits on the other side after varicocelectomy is still under investigation. So, in summary, it was a great talk, and now I welcome to all the panel members to address their questions and give a thought on our personal opinion about. For this presentation, there are some comments as I see, and thus I want to proceed immediately without any time loss. And I would like to invite Dr. Gökhan Kalik. He's the head of the Department of Urology in Medpol University in Istanbul to give his comments or questions. Please go ahead.
Thank you very much. Dear organizing committee, dear chairman, and dear colleagues. First of all, it's a great pleasure to be with you in this important meeting. I would like to thank Professor Kolbe for his comprehensive presentation. So, Professor Kolbe, will you please kindly comment on the necessity or indications, counterindications of differential vein ligation in primary or recurrent varicocele patients? And if there is a need to perform one, what are the possible complications that the surgeon might face? Thank you very much.
Professor, I can answer you in this way. Really, I never used to ligate the differential vein. Do you hear me?
Yes.
Do you hear me?
Mm-hmm. Yes, I can hear you.
If there is a recurrent varicocele, I usually suggest a spermatic vein flebography with sclerosation in order to check why I had the recurrence. So that is, normally we must ligate the internal spermatic vein, and at least in the case of a large varicocele, when I found in the spermatic cord a large external spermatic vein, I also ligate it. Otherwise, I don't touch it. But the differential vein is always respected.
Thank you very much.
Okay. The next question will be asked by Professor Marlon Martinez. He is from Manila, from the Philippines. And please go ahead, sir.
Thank you, Professor Germar, and thank you, Professor Kolbe, for that excellent talk. I have two questions. The first one is, since the testicle have several blood supplies, such as the testicular artery, the differential artery, and the cremasteric artery, so what do you do in the event you accidentally ligate or injure an artery? And my second question is, we have now the new video microscope, like the 4D 3K video microscope that can be used in performing a varicocelectomy. So what do you think this new video microscope can replace the standard operating microscope in the future? So thank you for this opportunity.
Professor Martinez, we know that the testis supply is made by the testicular artery, which is divided into internal testicular artery and the inferior testicular artery and the epididymal artery, and by the cremasteric artery and the basal artery. It will be mandatory to respect all the arterial supply to testis. Clinical experience with the Palomo technique seems to show that the more or less accidental ligation of
the particular artery causes no severe damage. If our aim when treating varicocele is to remove something damaging spermatogenesis, any arterial occlusion should be avoided. And about your second question, the new video microscope is a chapter of the technical progress. If research will show that the surgeon works better with it, when the surgeon training and the equipment will a separative room.
I think now we lost a little bit.
Yes.
So that I think was not clear for each one. At least I lost some of the last sentence from Professor Kolpi. Therefore, I would say now it's 5 o'clock, and to have no delay, we are proceeding. Sorry for that. So I would see for the next question, I would like to invite the Professor Dr. Quang Nguyen from Hanoi in Vietnam. It's a great pleasure. We had difficult to enter, but now he should be online. Please go ahead with your first question, and please consider the times to allow me.
Okay, because I have one comment and one question. The comment: the less traumatic the more effective is the case, the better. It's not preventing the condition. So, further studies are needed to assess which method is best for varicocele repair, especially between microsurgery and radiologists, which was mentioned. Some studies showing that varicocele is a bilateral disease. For example, the study by Professor Igor in 2004 showed that what was traditionally considered predominantly
As a moderator, I'm now intervening.
What is your opinion?
We have here one problem, I think. So apparently Vietnam is far away, and I'm so delighted that we cannot follow completely Dr. Nguyen. Therefore, he had excellent questions, basically. So therefore, I would say we have to proceed. So therefore, let me, with a great pleasure, to introduce, meanwhile, the next co-moderator for the sessions, Dr. Berg Hassan, a urologist again. He actually is working in the Lund University in Malmö, Sweden. Please, Dr. Berg, go ahead with your question, maybe hoping that we can hear you better than the other ones.
Thank you, Dr. Pinguera. I'm glad to be a part of the webinar, so thank you for giving me the opportunity to all. And it was an excellent talk by Professor Kolpi, and thank you for that. My question is that varicocele is a minor surgery and can be done with microsurgery. Does robotic surgery worth it? Is it a costly treatment option, especially in developing countries like Turkey, for example? And also, what's your preference for the surgery option? If it's a microsurgery, do you prefer the inguinal approach or the subinguinal approach? Thank you very much.
Okay.
Please, Professor Kolpi.
At the moment, I believe that, yes, you asked about robotic surgery. It's okay?
Yes, sir.
Yes. At the moment, I believe that the robotic surgery is not needed for treating varicocele, but in future, maybe it will be a problem of cost effectiveness. So maybe it will be used. I don't know. About a relative contraindication of radiologic sclerosation in pediatric population, I reported the data from the literature. Presumably, the causes is a subtlety of the child vessels to the diameter of the angiocatheters. And about the approach, personally, I prefer subinguinal approach, which is less traumatic and pain-free because you have not to open the inguinal canal. After an experience with the subinguinal microsurgery, currently I use a subinguinal sclerosation, but this is my personal technique, which was described in a few papers. But really, I prefer the sublingual approach.
Excellent. Thank you very much, Professor Kolpi, for these answers, for unique and excellent, outstanding presentations. Furthermore, not only have introduced us to the latest advance in varicocele surgical therapy to improve male fertility, but we all appreciate your personal wealth and clinical experience and expertise over so many years. Thanks a lot from my side. Therefore, even less, we missed some questions from Vietnam. I think we'll conclude our session right now, and I will pass the floor to the next presenter of session 4 without any delay. Thank you all around the world for your interest in attending the session, and my personal gratitude to the Congress organization team under the auspices and presidency of Professor Ashok Agarwal and his chairmen, Professor Rubin Shah and Dr. Murad Gül. Thanks a lot for all to be here. Bye-bye.
You are now live. Bjornis, you can start.
Okay. Thank you very much for this invitation and this wonderful webinar. I would like to congratulate the organization committee, my friend Murad, for this wonderful webinar, and Professor Agarwal. I will do first a small summary of the wonderful speech of Professor Saleh. I think that what we can say as a summary is that really high level of evidence is lacking. We're really unsure if, because most of the studies are retrospective, we have only few studies are prospective with pregnancy rate as a primary outcome. And most of the studies usually have a small sample size. We don't really have investigated all confounder factors so far, so we cannot really prevent the outcome of a varicocele repair. There are still no high evidence regarding the predictive role of new examinations like the sperm DNA fragmentation index or the oxidative stress. There are no evidence how we can predict better results in patients with recurrence after varicocelectomy. And there is no real evidence on predictive factors regarding varicocele repair prior to ART. But what we can say, the best predictors that we have so far for a successful outcome after a varicocelectomy is that we need patients that are in young age, that the female partners also are in young age, that the duration of the infertility is short. We would happily have normal testicular size. Please repair only clinical varicoceles, especially grade 2 or 3. If bilateral clinical varicoceles are present, do both sides. And if you can do it microsurgical subinguinal, prefer this method. Before proceeding to my co-moderators, Dr. Tuncay Toprak, Dr. Hakan Keskin, Dr. Teimur Mostafa, and Dr. Vidi Atmoko. We have 4 questions from the audience that they have written, and I would like to mention them before so that Professor Saleh would have some time to consider them as well. Dr. Mehmet Cetin asks if there is a cutoff value regarding testicular volume in adolescent patients with testicular hypotrophy. Professor Ümit Gül asks, what is your approach to the use of food supplements in patients whose semen parameters do not improve despite successful surgery? Dr. Jackson Hakim asks, which has a better outcome between inguinal and subinguinal approach? And Dr. Sivam Priyadarshi asks if hormonal assay, including FSH and testosterone levels, could be used as prognostic markers. And now I would like to invite Dr. Tunkai Toprak to ask his question and do his comment to the speech of Professor Saleh.
Yes, thank you, Dr. Ioannis. I want to thank Dr. Ramadan for his nice presentation. My question will be, does varicocele incidence decreases as body mass index increases? He mentioned it somewhere. Have I got it right? Can you elaborate a bit, Dr. Saleh? Thank you.
Thank you, Dr. Toprak. And now we can proceed to the question or comment from Dr. Hakan Keskin.
Hello to everyone. My name is Hakan Keskin, and I am attending this meeting from Hacettepe University, Ankara, Turkey. I thank you to Professor Agarwal and Dr. Gül and everyone for arranging this international meeting. It is so thrilling to see lots of attendees from all around the world. And before my question, I want to thank also to Professor Saleh for his enlightening presentation. And here is my question. You have mentioned the best outcomes comes from the patients with normal hormone levels after varicocele repair. So what should we expect from the patients with hypogonadism or such as low testosterone levels after varicocele repair? And how should we manage the follow-up process after the operation? Thank you.
Thank you, Dr. Keskin. And now I would invite Dr. Teymur Mostafa for his question.
Thanks, Dr. Saleh, for your nice presentation. Are there potential biochemical markers that might foretell about successful varicocelectomy outcome? This is my question.
Thank you, Dr. Mostafa. And I would like now to invite Dr. Vidi Atmoko also to ask and his comment.
Yeah, thank you, Dr. Ioannis, Prof. Agaro, and also thank you for the wonderful presentation from Professor Saleh. So, as clinician, age and grade of varicocele, hormonal profile, and also testicular volume and sperm parameter are the most commonly used predictor of the successful VR result. However, more research may be warranted to look at the best predictors of the VR outcomes, as the several studies have the contradictory results. And also, the larger varicocele will most likely result in a more remarkable improvement of semen parameters as it has a worse baseline. However, it may not serve as the predictor of the favorable outcome regarding the pregnancy rates. And my question is, if the case in infertile men with large bilateral varicoceles with the testicular hypertrophy, let's say the volume less than 5 millimeter, and the abnormal semen analysis, would you still recommend the varicocele repair for this patient? Thank you.
Thank you, everyone, for your questions. And now the podium is to Dr. Saleh to answer these questions and address the comments. And another time, congratulations from your wonderful presentation. I believe there is a problem hearing you, Professor Saleh.
Please unmute yourself, Ramadan.
Ramadan, we cannot hear you.
They are online.
You can speak, Ramadan.
Hello.
Yeah, we can hear you now.
We can hear you now, yes.
Okay. Actually, let me start with answering the question, the first question by Dr. Tubrak regarding the relationship between varicocele and body mass index. There is a report indicating that the prevalence of varicocele among men with a high body mass index is decreased. So the more the body weight, the less the prevalence or incidence of varicocele. Actually, the exact explanation for this observation is not clear. And anyway, regarding the predictive value of body mass index for the outcome of varicocele repair, the literature has no evidence on the predictive value of body mass index on the outcome of varicocele repair. Regarding the second question by Dr. Hakan on the relationship of hypogonadism or low testosterone level in patients with varicocele and the results of varicocele repair, Dr. Amarnath and other speakers in this meeting has very nicely answered this question. Of course, we know that varicocele repair have positive impact on the reproductive hormone, but the question would be whether the setup is a state of hypogonadism or infertility status. Anyway, as I mentioned in the presentation, the two hormones that are correlated with positive outcome of varicocele repair are follicle stimulating hormone and total testosterone. And it would be expected that if there is baseline or preoperative low level of testosterone in a patient who is eligible for varicocele repair for infertility problem, there is a great possibility that the testosterone level will normalize or will return back to the normal level. Regarding the third question by Dr. Taimur on biochemical markers that could be predictive of varicocele repair, unfortunately, currently there is no specific or important biochemical marker that could have high predictive value for the outcome of varicocele repair. And if we can discover or detect something like this, I think this will be very interesting and very important. One of the potential biomarkers that could play a role in the near future may be the oxidants or the oxidative stress markers in semen. Maybe the limitation now is there is no standardized technique or method for assessment of seminal oxidative stress in semen, and the current or the most recent WHO manual for semen analysis still considers seminal oxidative stress as of research interest. And I think in near future we need a standardized technique for assessment of seminal oxidative stress that plays an important role in varicocele, and this could play also an important predictive role in terms of predicting the outcome of varicocele repair. The last question was by Dr. Vidi. He is questioning about the size of varicocele. As I mentioned in the presentation, also the guidelines and the three largest professional societies in the reproductive field, they all consider the grade of varicocele as one of the important parameters, and the more the size of the varicocele, the better would be the outcome of varicocele repair. Definitely, if there is testicular atrophy, together with other indications for varicocele repair, having bilateral clinical varicocele, having abnormal sperm parameters, including sperm DNA fragmentation, and together with reduced testicular size, I think this is a strict indication for varicocele repair in this situation. Maybe I can cover some of the questions by the audiences. If I remember, the one question was the cutoff value of testicular volume in adolescents in order to recommend varicocele repair. I don't think there is a cutoff value, and the age of adolescence also should be carefully determined. The testicular volume is variable depending on the age, and I think it should be carefully assessed if there is discrepancy between one test and other which is having varicocele, and after follow-up for few months of the growth of the testes, I think a decision as to undergo varicocele repair or not can be decided.
Thank you, Professor Saleh. Unfortunately, we don't have much more time to cover all the questions. We will try to answer them per email to the audience. As summarizing, I would like to say that young patients with bilateral large varicoceles, normal testicular size, they will be benefit from a microsurgical subinguinal repair. And I would like now to ask to give the microphone to Professor Gian Maria Bussetto to cover the question and answer session from Team 5. Thank you all for your good cooperation and the good work, and thank you the organization committee for this invitation and this organization. Thank you all.
Hi, everybody. So we are from the team number 5, and we are leading the last session. And we have so many interesting questions regarding the following speech. And so I would like to start immediately to use our 15 minutes in the best way that we can. So I just want to make a fast remind on the points, on the important points. So we discussed about the role of varicocele repair in non-obstructive azoospermia, the role of the testicular biopsy after or during the varicocelectomy in NOAH. What about the subclinical varicocele, bilateral or not? What about the varicocelectomy in bilateral or unilateral situation? And finally, which is the role of the antioxidant supplementation before and or after the varicocele repair. So I just would like to start giving the speech to one of the first co-moderators, Dr. Kadir Boku. He has 2 interesting questions that he would like to do to the speech. So, Dr. Kadir, please go ahead.
Thank you so much, Professor Gianmari. I would like to express my pleasure to have been invited as co-moderator this wonderful meeting, and thanks to all speakers for their grand presentations. Many topics has mentioned before that our session, but as Dr. Rupen Shah has stated, I also consider there are significant differences between current clinical guidelines, recommendations, and daily clinical approach regarding the management of men with subclinical varicocele. Although there is no evidence for surgical repair of bilateral or unilateral subclinical varicocele, but I just wonder how should manage to in patients with abnormal semen parameters and the only explainable reason bilateral or unilateral subclinical varicocele. Is your primary preference antioxidant treatment, or can be surgical repair performed these patients in some conditions? Thank you.
Dr. Rubin?
I thought we were going to take all the questions together, but this is also a good way of doing it. So, Dr. Kadir, I think this is a common situation people face, that we must find an explanation. semen parameters may be abnormal for a variety of reasons. And just because there's a subclinical varicocele and we are desperate to find a reason doesn't mean we have to attribute the abnormal semen parameters to the subclinical varicocele. And we found this even during the survey that we just concluded on sperm DNA fragmentation. And the question kept on popping up, but will you treat a subclinical varicocele if there's high SDF? If you believe subclinical varicocele does not have an impact, it does not have an impact. If you don't have a reason, you don't have a reason, but there's no justification tagging a subclinical varicocele onto the problem.
Thank you so much.
Do you have any other question?
If we have time, one question, in addition, one question.
One fast question, you can go.
Okay, there is another issue that I think is controversial and specific condition, and many audience want to ask these questions. I wonder about participants' opinions about the management of varicocele in prepubertal boys. Since these patients cannot give semen samples, testicular volume differences is showed a surgical indication. But is this just alone enough? Can these patients be follow-up the age? They can give semen samples by performing physical examination and ultrasound at regular intervals. How do these two approaches affect to their fertility capacity in the future? Thank you.
So a very good question, and actually two questions. One, is testicular volume alone an indication for operation of an adolescent varicocele? So the guideline is that just because there's discrepancy, you don't operate immediately. Wait to see if there is catch-up growth, because in many instances, there may be a discrepancy, and during follow-up over a 6-month, 1-year period, it catches up and the two testes are equal, in which case surgery is not indicated. There is one paper suggesting that catch-up growth is less likely to occur if the velocity of reflux is more than 32 centimeters per second. So the question, is volume alone sufficient? Yes, but not at one point in time, followed up over a prolonged period of time. If discrepancy in size permits, then there is no need to wait till the patient can give a semen analysis. Second question, how does it affect future fertility? Very difficult to study this, but there was one study from Belgium where adolescent boys picked up in a school program were offered the choice. Half were treated with radiographic occlusion, half were not. 20 years later, when they were adults, they were followed up, and there was no difference in the fertility rates between the group whose varicocele was treated and those whose varicocele was not treated.
Thank you so much. I have no question about it.
So we thank you, Dr. Kadir, for his question, for interesting topics he raised. And I would like to give the talk to Dr. Fernando Solorzano that has, I think, 2 other questions that could be done to Dr. Rupin. So go ahead, please, Fernando.
Thank you so much, Dr. Buseto. Greetings from Mexico. Good afternoon to everyone. Thank you for this invitation. I'm very glad. And also to congratulate all the speakers. It was an amazing meeting. For me, as a reproductive medicine specialist and an IVF expert, most of the occasions patients come for counseling if they can do a varicocelectomy or maybe doing a treatment not so invasive. So the topic of antioxidants, I think it's very important for many patients. My question will be if there is any in the reviews or any recommendation for a special antioxidant to use, or a combination of antioxidants, because we know there is a lot of products that is in the market around the world. And also, if there is a specific alteration of the parameters that can be improved with these antioxidant combinations recommendation.
Thank you for that very nice question. So the question was, one, which antioxidants are better. And usually when I'm asked that question, I ask, who is the sponsor of this meeting? And that tells you which combination to use. But surprisingly, again, at the ASRM meeting, which is going to be held this year, one of the 6 papers from GF is on antioxidants and varicocele. And the surprising conclusion of the abstract which we are presenting is that there was no difference in improvement when you used a single antioxidant or a combination of antioxidants. Now, that is contrary to what we know on a theoretical basis, because theoretically different antioxidants act on the sperm at different levels, and therefore theoretically a combination should be better. But this one study meta-analysis that we are presenting, and you can find it on the GAF website, the entire abstract, actually showed that there's no difference. So the bottom line is, at this point, we do not know whether one is superior to the other. The recent meta-analysis from Cochrane, which concluded that antioxidants do improve pregnancy rates, also stated that there was no evidence pointing in favor of any one specific antioxidant. So in that sense, any antioxidant will probably help. Is there any specific picture where antioxidants would help? Yes, in fact, that's a big topic coming up, that maybe those men with oligoasthenoteratozoospermia who have evidence of oxidative stress measured by any of the methods available are probably the specific group where antioxidants are most likely to help.
So we thank you, even Dr. Fernando, for his interesting question, and we thank Dr. Ropin for the answer. So now I would like to ask to Dr. Puk Nguyen. I'm sorry for the pronunciation. I don't know if it's correct. Anyhow, I believe that he has a couple of questions as well. So I ask him to go ahead with his question. Thank you.
Thank you, Professor Busetto. I'm Phước Nguyễn, come from Vietnam, and I would like to ask some question. Thank you for Dr. Rupin and his excellent presentation. And I think that some other special consideration in varicocele treatment that we maybe consider, including first, the appropriate duration to follow post-operation for sperm in ejaculation in azoospermia case, and another is the time to decide on micro-TC. Thank you very much.
So as I understand it, the question is that how long after varicocele repair should one consider either a micro-TC or expect sperm in the semen? Again, I think that was one of the topics that we have studied in our global survey, but that was time to optimal improvement. And both the guidelines and the survey suggest that 1 to 2 spermatogenic cycles, and the more severe the oligoastheno, the longer it may take to improve. So if you're looking at an azoospermic male, one would expect that maybe up to 6 months. But the tricky thing which has been pointed out in literature is that after a varicocele ligation for an azoospermic male, sometimes sperm appear and then they disappear. So it's probably a good idea to monitor every few months up to a period of 6 to 9 months and then take a final decision. But if you get sperm, say 2 months or 3 months, freeze that sample, because at 6 months, maybe he will improve or maybe he may become azoospermic again.
Okay, so thank you even for this other response. So I would like to call the latest co-moderators, Dr. Konstantinos Makarounis, and I said thank you to Dr. Puk Nguyen for his interesting question. So Konstantinos, please go ahead from Greece with your final questions.
Thank you very much for the invitation. It was an excellent speech. It was an excellent webinar. It came spontaneous to me to ask Dr. Shah, is there any predictor from biopsy to azoospermia in case of varicocele repair that we can predict, maybe even in study now, like the new mRNAs, if we can predict that?
Sì, sono collegato con gli Stati Uniti.
Do you understand my question?
Yeah, your question was, in the biopsy, is there a specific predictor in terms of his...
Not the pathology, but if we can predict before doing the biopsy?
In terms of any markers? No, I'm not aware of any.
Okay. And do you think that we have to measure oxidative stress before giving antioxidants?
Yes, that would certainly be ideal, because it's not only a question of identifying which patient is more likely to benefit, but it might also prevent harm, because if we give too many antioxidants to someone who does not have does not have oxidative stress, we may actually have the reverse effect and produce reductive stress, which is also harmful. So right now, most of us, and that's what the global survey, which we had done earlier, a previous survey on antioxidants showed, is that very few people measure it, but most people use it. But ideally, yes, one would like to measure the oxidative stress to identify which subgroup should be treated, and maybe even monitor the response to therapy by monitoring the change in oxidative stress in response to therapy.
Da moderatore questa sessione del Global Andrology Forum.
Okay, thank you very much. Even in case of a varicocelectomy, I intend.
Yes.
Okay, thank you. Thank you very much.
Thank you.
So thanks to all the co-moderators for their excellent questions, for their excellent job. Thanks to Dr. Lupin for his answer. So I think we have just a couple of minutes for a couple of questions from the audience. So I would like to start with this question, that is, what about measuring specific deficits, for example, level of L-carnitine in the semen, and provide target antioxidant treatment? What do you think, Dr. Lupin?
Yeah, it sounds like a very good idea, though I have no practical experience with that.
Oh, so another one. So what is the ideal minimum treatment time of antioxidant in varicocele to check for the effect?
So again, interestingly, I think our ASRM abstracts will be very useful to everyone. We've looked at this and we found that beyond 3 months, there was no additional benefit of giving antioxidants. So if it has not improved by 3 months, it doesn't seem to improve further.
Yeah, I agree with you. I think that from 3 to 6 months is the ideal period for treating a patient with an antioxidant therapy. So I believe I can do just another question, that is varicocele, if varicocele is veined more than 3 millimeters, why should we ligate all the internal spermatic vein? Maybe I can reply to this question, and I can say that is important because in order to obtain the perfect ligation and the perfect resolution of the varicocele, it's important to ligate all the veins in order to avoid any other problems and to have a successful surgery. So after this, I believe that we have finished our time. So I think that I can pass the talk to Professor Agarwal, that he will close our meeting. And I would like to thank all the co-moderators, Dr. Lupin, all the audience. And I would like to thank for this successful meeting. This is the first Global Andrology Forum meeting. I believe that there will be farther and farther to increase day by day our knowledge. So thanks to all of you.
Thank you.
Thank you very much.
It started.
I can't see my slide on the shared. Yeah, okay, here we are. So we've had a wonderful session, excellent lectures, and everyone has summarized the talk very well. So this is just a very quick revision. So the first talk on the clinical and sonographic diagnosis, the answer was ultrasound should not be routinely used to diagnose a varicocele, especially when there is no clinical varicocele. It is useful in specific situations where it is difficult to diagnose a varicocele due to physical conditions. In the comment, it was pointed out that the ultrasound should also be done in a warm room with standardization. The second talk covered who should be undergoing a varicocele repair. And apart from the standard indication of oligoasthenoteratozoospermia, it was suggested that even men with normal semen parameters but elevated STF can be candidates for surgery. And in some cases, varicocele repair before ART could improve both the pregnancy and the live birth rates, considering, of course, the other confounding female factors. The varicocele for hypogonadism was tricky and may be done in selected situations, and it could be done for testicular pain when the pain was specific. Technical aspects were discussed in talk 3. It was universally suggested that while microsurgical varicocelectomy is now the gold standard, there are other alternatives. The evidence favoring one over the other is more related to side effects and recurrence rather than actual improvement. And eventually the surgeon should do what they're best able to do. So under conditions where there's no microscope, even a loop-assisted varicocelectomy may be adequate. Ramadan in his excellent talk covered the possible outcome measures and predictors of varicocele repair. And while acknowledging the confounding factors, he did point out that younger patients with a shorter duration and a relatively higher initial sperm count with a large varicocele are most likely to have the most clinically significant improvement. Normal FSH and a normal testosterone are also favorable predictors. Finally, in the last talk, special considerations, varicocele repair could be considered in non-azospermic, in non-obstructive azospermia. With a very guarded prognosis, testicular biopsy may help guide this decision-making. Pure subclinical varicocele should not be operated, but if there is a left clinical and right subclinical, perhaps there's a role for bilateral varicocele ligation. And finally, there's a role for antioxidant therapy, either before varicocele surgery or if there is no benefit after varicocele surgery. So with that summary, it is over to Dr. Ashok Agarwal to finally conclude the meeting.
Thank you, Rupin. Good morning and good afternoon and good evening for all the people who have joined us. We have more than 1,012 registration, which is the highest number of registration for a medical webinar in the whole world. And we have candidates from more than 70 countries. We are still counting. But more importantly, I want to thank every single of our speaker, our moderators, and co-moderators from more than 30 countries. I want to actually take this moment to talk about and pay tribute to a very, very important andrologist of Turkey, Professor Ana Farta. And I want to ask my colleague, Dr. Murat, to say a few words about this distinguished person.
Thank you, Professor Agarwal. Unfortunately, today we received very saddening news. In Turkey, one of our most prominent figure, Professor Kadri Anafarta, who has passed away today, has done so much contributions for andrology and urology. And we are really sorry for his loss, and we present our deepest sympathy to his family on behalf of Society of Surgical Urological Surgery in Turkey. Thank you. You can continue.
Thank you very much, Dr. Murat. We again from the Global Andrology Forum, which is the group which has sponsored and collaborated on this webinar. We want to convey our deepest condolences to the family of Professor Anafarta and all our Turkish colleagues who are attending today. Now we want to very quickly, before we end the program, tell you about the Global Andrology Forum, which has created this program with our Turkish colleague. What is Global Andrology Forum? It was started about 2 years ago. It's an online program which for collaborating for andrological research, and it was formalized as the Global Andrology Forum. It has by now about 500 participants from 70 countries and 6 continents. And our main interest is to really study about, this is our mission statement, is to conduct the highest quality research, including systematic review and meta-analysis on controversial topics in male infertility. So this is, we want to promote educational research activities, including scientific meeting, tutorial, online test, and comprehensive training in clinical, in research methodology. Furthermore, our vision is to create a global collaboration of clinicians and researchers to promote scientific excellence in the field of andrology. We are trying to reshape the future of andrology. This is a breakdown of our total membership, which has crossed almost 500 now, and from more than 70 countries. If somebody wants to learn more about it and join us, because the membership is free, there is no expectation of anything except that you have an interest to learn about andrology, or you are already working in andrology and would like to collaborate with us. So go to www.globalandrologyforum.com, or you can also on that link, you can apply for membership, and also you can write to me or to my colleagues, and we will be happy to provide you the information. This is the management structure with many of the colleagues are here today. Dr. Rupin Shah and Dr. Florence Boitrel, Dr. Ramadan, who gave a presentation today. So Dr. Rupin and Ramadan are part of this. Then we have several guest advisors that you see, and some of them were part of the program today as well. This entire program was invited to write an editorial, so we did, and this editorial was published. This is the editorial, a worldwide innovative online initiative to bridge the gaps in research and clinical practice of male infertility and sexual health. So you can read about it. It was published just a few weeks ago, and that describes the initiative that we are talking and all the good things that we have done in this very short period of time. I want to also announce this very important webinar that is going to be happening in about a month's time. This is the webinar which is organized by our colleague from Indonesia, the Indonesian Society of Andrology Urology, in collaboration with the Global Andrology Forum. The chief organizer is Professor Poncho Birovo, who was one of the moderators in today's program. So please join us in this program. Again, if you need information about this, you can write to us. We want to say special thanks to our team of technical team. And these are some of the players here: Miss Asli Oskan, Emery Basturk, but we had almost 6 or 7 more consultants who helped manage and engineer this program. I also want to thank Ms. Liliana Ramirez, who is our main coordinator, and she helped with arranging this program. Before I say goodbye to all of you, I also want to say that those of you who have attended the program, and if you want a certificate of today's attendance, we have created a very nice certificate, and you can write to the organizers, and there is a questionnaire that you have to complete, and as a result of that, you will be given a choice to fill in the information to apply for the certificate for attendance of that. If you would like to have a recording of today's program, that will be again made available by the organizers once they have completed the necessary work to create the video. Third, for many of you who have asked online questions, we apologize because of the time. We were not able to answer many of the questions because we already had many questions from our expert panel. So the questions that were asked by the audience, we are going to send answers to them via email. So please bear with us, and we will try to attend to all your questions that have come, and those will be answered in time. So this concludes our presentation for today's medical webinar that was created with the Turkish Society of Andrology, their Andrology Working Group, with my colleague Dr. Murat Gul, and co-chairman Dr. Rupin Shah, and this is from the Global Andrology Forum. Thank you and goodbye.